We are very pleased to have Congresswoman Colleen Hansa, who is here to introduce the speakers and to introduce us to, and has been such a fantastic leader on this issue. And so just a quick bio, Congresswoman Hanabusa proudly represents Hawaii's 1st Congressional District and brings to Washington a passionate, hardworking, and fearless approach to advocacy, and has committed her entire career to providing for the people of Hawaii while preserving the unique values and traditions that define the aloha spirit. And since 1998, when Congresswoman first was elected to a public office, she has really been a champion in dedicating her talents and desires to improving the lives of Hawaii's working families, and standing up for the underserved and championing the issues of those communities, especially as this briefing recognizes the needs of the COFA migrant population. And so right now, we are pleased that there is legislation that is currently pending in the House that has been introduced by the Congresswoman to support the rights of access to health care for COFA migrants, and we're really pleased to have you here. So thank you so much.
Thank you. Thank you very much. And thank you all for being here. This is a very important issue, and unfortunately, its impact is felt in just certain areas, and that's one of the reasons why I think we do not have more members of Congress really standing up and advocating for this. But let me first begin by, the reason I'm reading it because I want to get all of it right. Asian and Pacific Islander American Health Forum and the Association of Asian Pacific Community Health Organizations basically putting on this event. The issue, like I said, is very important. Certain areas, as you know, are affected more than others by the whole issue of the COFA migrants and the impacts. But let me begin by being very clear, and this is where I think that it is unfortunate and where the disconnect arrives in Congress, is the fact that people do not understand the reason why we have COFA, the Compacts of Free Association. They do not understand what the freely associated states are. They do not understand that there are 3 different compacts that we are dealing with, and they do not understand, or they have forgotten, unfortunately, why we are here. And I think one of the great handouts is this Life, Liberty, and Justice for All, which really sets it out. Because I think that if people just nationally were to realize and recognize that between 1946 and 1958, the United States conducted 67 nuclear tests, equivalent to 7,200 Hiroshima bombs within the Marshall Islands. And that what the compacts were a result of was because of that wrong and the obligation to make it right, or to ensure that the people who are the victims, really, of those tests are given and afforded the opportunity to have medical care, to have the ability to make a living. And the other thing that I think is really misunderstood is people believe that though there is no real requirement, like how people think of immigration, that COFA migrants have become members of our communities, our respective communities, and that there are approximately 200,000 of them worldwide, and that we should know that they are employed or in our school, and 65% already have health insurance, and that less than 3% are receiving any form of welfare. These are important numbers because it is such a misunderstood group. But because of that misunderstanding, we have had this major problem of asking people to step forward and make things right. You may know that one of the best indicators of how low a priority it is the amount of funds those areas who serve COFA migrants receive from the federal government. It is about 30-some-odd million a year that they must all share. And that, unfortunately, is what causes, I believe, within the respective states and territories that carry a lot of the obligations of the federal government, that you have people within those states and those territories who feel like somehow it is unfair. What we are here, I hope, to discuss and to promote is HR 912, which is to restore Medicaid coverage. Believe it or not, Medicaid coverage was available, and something happened. No one can quite tell me what it was. Something happened where the COFA migrants were taken off of Medicaid, and that then augmented the problem. Especially, like I can tell you about Hawaii. Hawaii provides the coverage, and it's full cost to the state, and it amounts to about $42 million a year. So you can imagine when the state has to bear this burden, doesn't see any compensation for the federal government, that too causes a bit of conflict. Notwithstanding, I must say that I am proud of the state of Hawaii because they have stepped up and they do recognize that this is an obligation that we have and that they are part of our community. And I like to think that it is the unique characteristics of Hawaii, the aloha spirit and the sense of ohana, as we say, that really is the foundation for why. That does not, however, eliminate the fact that there are people who feel like it is an unfair burden, and it is an unfair burden. But we miseducate people here before they will begin to recognize that it is the federal government's obligation caused by these wrongs in the past that we must step up and be accountable for. So it is with great pleasure that I get to introduce this wonderful panel, and I hope that all of you who are here will learn from them as I believe I was. This subject, as much as I think it's something that I've studied and I understand, it is always amazing how much more you can learn. Especially, I hope that we'll have a briefing on what the people experience. And let me just explain to you, I represented, when I was in the state legislature, the part of the island of Oahu known as the Waianae Coast. And we have the largest percentage of Native peoples. And that is why rights of Native peoples, wrongs that have happened to all Native peoples is such a high priority to me. Let me introduce your speakers, and they're wonderful. I have Kathy Cochin as the first speaker. She is President and CEO of the Asian and Pacific Islander American Health Forum. Kathy has more than 30 years of experience serving nonprofit community health organizations as a staffer, consultant, and in governance roles to improve health care and community clinics throughout the country. Most recently, Kathy was Program Director for the Community Clinics Initiative, which supports the infrastructure development of community clinics and health centers in California, and that's of course through skills of grant making, information sharing, and research. And in her role at the Health Forum, Kathy works to influence policy, mobilize community, and strengthen programs to improve the health of Asian Americans, Native Hawaiians, and Pacific Islanders. So we thank Kathy for being here. Then, from my state of Hawaii, is Dr. Neil Palafax. And Dr. Palafax is professor and former chair of the Department of Family Medicine and Community Health at the John A. Burns School of Medicine at the University of Hawaii. He worked in the Marshall Islands in 1983 as a National Health Service Corps physician, where he became co-medical director of a U.S.-funded program to care for the radiation-affected people of the Marshall Islands. So Dr. Palafax will give us the real impact that the testing did. Since then, Dr. Palafax has been working with Pacific healthcare disparities and developing cancer health care systems in Guam, American Samoa, CNMI, Micronesia, and Palau. He has led 5 cancer care projects in the Pacific and was instrumental in establishing the Cancer Council of the Pacific Islands, which coordinates planning and development with the National Institute of Health. And we're very fortunate to have him here because I think that one of the discussions that you hear all the time, especially in Washington, is, well, it's been so many years, so what are the impacts today? And I think Dr. Palafax will be able to put all of that to rest as he shares his great experience. Our third speaker, we'll have a special guest, Kathy Grisham, who is the Executive Director of Community Clinics at St. Francis House. Community Clinic is a federally qualified health center in Northwest Arkansas, where the largest population of COFA migrants in the continental United States reside. The clinic offers a range of healthcare services at 7 sites in the region and employ bilingual staff members offering services to the Marshallese population. Kathy was instrumental in expanding the clinic, which serves 5,000 patients when she first started to the number 30,000 that she serves today. Imagine 5,000 to 30,000. Thank you very much, Kathy. And I want to say that the one state that we, as we work through the COFA issues, have always looked to partner with is Arkansas, because Arkansas has a large population here. And I think that speaks a lot, not only for the state, but it also speaks to the population itself. By that I mean, when you look at our, as I call them, our fellow Pacific Islanders, and I say that because, of course, Hawaii, you find that the sense of family, the sense of being welcome is very critical. So to Arkansas's credit, I believe that what you provided for the COFA migrants there is a sense of being welcome and a sense of belonging. And that is why this is so important to places like Hawaii, which has a large population, because I don't ever want to lose that sense, which I think gets in jeopardy because the federal government doesn't do its part. That as people feel that there's just this much that we can share, as they feel that it's being taken away from them, that's where we're going to lose the sense of family, the sense of being welcome, and truly the sense of respect and the sense that this is the right thing to do. So I thank each and every one of you for being here, who are willing to listen and to learn along with me from these great experts that we have. So with that, Kathy, and I'll turn it on to you.
Thank you so much, Representative Hanabusa, and thank you for your leadership on this issue. As immigration reform comes to the forefront this summer, we must take the opportunity to honor America's duty and commitment, as the representative has talked about, to the Pacific. Representative Hanabusa went through a lot of the history that's really relevant, that since just after World War II, America has developed a unique relationship with Pacific Island nations known as the Freely Associated States, and this includes the 3 nations of the Republic of the Marshall Islands, the Federated States of Micronesia, and the Republic of Palau. The relationship was intended to be reflective of the contributions that each of these Pacific nations has made to the United States' military strategic position. In return for the unfettered military access to these Pacific waters and an acknowledgement of the nuclear test bombing that was undertaken in these jurisdictions, the U.S. entered into treaties known as the Compact of Free Association, or COFA. As part of the treaties, the U.S. would have to guarantee the health, education, housing, and infrastructure of these nations. And in addition, this phrase of being freely associating meant that COFA migrants were permitted and are permitted to freely live, work, and travel in the United States and go back and forth. So it's not about immigration, as Representative Hanabusa spoke to. And currently, there are over 56,000 COFA migrants residing in the United States, with the majority living in Guam and Hawaii. Federal law, however, has failed to live up to its promise. As the representative noted, COFA migrants contribute greatly to this nation's economy, not only as working adults, but also paying taxes and participating civically, but are unfairly excluded from the federal safety net programs, and in particular, Medicaid. This wasn't always the case, though. Before 1996, COFA migrants were eligible for Medicaid and the Food Stamp Credit Program, also known as SNAP. However, in 1996, with the law that we all know as welfare reform, it was called the Personal Responsibility and Work Opportunity Reconciliation Act, it changed the category of who was eligible, and in particular, non-citizens were prohibited from accessing Medicaid. So as a result, not intentionally focusing on COFA migrants, but because of this non-citizen exclusion, COFA migrants lost their eligibility for public benefit programs such as Medicaid, and are considered, quote, not qualified for these programs. In the aftermath of these changes, though, many more generous states were able to find a way to support COFA migrants for their Medicaid programs and the state-only programs. And we heard that Hawaii is one of those. Hawaii has borne a particular burden due to the failure of the federal government to live up to its commitments. And as well, 9 states currently have COFA migrant populations that exceed 1,000, which include California, Washington, Oregon, Utah, Oklahoma, Florida, Arkansas, Missouri, Arizona, and all of them are facing incredible fiscal constraints. In your packet, there is a chart of where we have the largest concentration of COFA migrants in which states and congressional districts. And the human toll is really great. Many COFA migrants, especially due to the conditions in their home countries, as well as the exposure to radiation, face serious health conditions, and I know Kathy will speak to that as well. There are higher rates of obesity, diabetes, hypertension, and cardiovascular disease, as well as communicable diseases. And even the Department of Interior's Inspector General reported that many of these health disparities that COFA migrants experience are facilitated by the lack of health care back in their home countries. While the Affordable Care Act will provide some relief, it really is incomplete. The cost will be too high in the marketplaces because many of the migrants live in lower paid jobs, but also because of the exclusion from Medicaid. And despite some expansions in Medicaid that states can opt into, the limitation for COFA migrants from being eligible really will limit the full promise of the Affordable Care Act for these populations as well. So for us at the Health Forum, and I think I can speak for APCHO as well, this is a matter of fairness and responsibility on the part of the federal government to live up to its commitment to these nations and to these jurisdictions. The responsibility of the federal government is to share in the health care costs of COFA migrants throughout the country, and especially in those states where there are high concentrations. And we really need to think about the equity for COFA migrants because they do work and pay taxes, and they are contributing into the entire system. We've really appreciated that there have been congressional champions from Hawaii and from Guam over the last 17 years since the Welfare Reform Act barred them from Medicaid. And in your packet is a chart of some of the congressional champions who have really brought this forward to their colleagues. We want to recognize Senator Akaka, Representatives Honda, Cordayo, Lee, and Hirono as when she was a congresswoman in helping to push this in Congress, and now Representative Hanabusa in the 113th Congress. And we also want to thank Senator Hirono for her leadership in the Senate, where she has included this in the Senate Immigration Reform Bill, S744, to restore Medicaid eligibility for COFA migrants. So now it is time for the House to act. We are so thankful for Congresswoman Hanabusa to sponsor House Bill 912 to restore Medicaid restoration to COFA migrants. From the Health Forum and APCHO's perspective, we also see this as an opportunity, along with the immigration reform debate, to think about how to include non-citizens in accessing public programs. And we really feel that this bill would bring enormous relief to all the states that have significant compact of free association migrants, but especially in Hawaii, Arkansas, and other places. So now is the time for the federal government to really fulfill its commitments and its obligations and correct the error that happened in the Welfare Reform Bill of 1996. And I'm happy to answer questions later.
The ultimate purpose of this is to be able to speak compact ease. This is compact ease 101. So, that's what we're trying to do. And so, first is that in the U.S. Associated Pacific, as you may or may not know, there's territories and commonwealths, and there's free associated states. So Guam and American Samoa are the territories, and like Puerto Rico, there's a commonwealth called the Northern Mariana Islands. These are important because the compact folks also go to these areas. Then there's the free associated states. Federated States of Micronesia, Republic of the Marshall Islands, Republic of Palau. They are linked to the United States by a treaty called the Compact. It's called free associated states because they are freely associated with the United States. So this is a map, and many of you are probably familiar with this. Upper right-hand corner, Hawaii. Lower right, on your right, is American Samoa, the target is Marshall Islands. The lateral oval is the Federated States of Micronesia. Upper left is Commonwealth of Northern Marianas. Under that is Guam. The small left circle at the far left is the Republic of Palau. So that's the general layout. And where the target is and the oval is, and that small circle, those are the compact nations in that latitude. So these are the relative populations, very small populations, and now many of them have come to the United States. Now the first thing to know about compactees and Micronesianese is a lot of people they use compact, Micronesian very freely. Micronesian is not a Micronesian, is not a Micronesian. So if you just look at this, people from the FSM are Micronesians, but so are the people from CNMI, Guam, Armai, and Republic of Palau. So are the people from Kiribati. So to use the correct language is very important. And I'll just leave it there, and we can go over it at the end of who's Micronesian and who's not. But people actually get offended because they say we're not part of the compact impact issue, and they get and so you actually fragment the Pacific peoples because they want to stay a part of it. Okay, stay not a part of it. This is a slide of one of the atolls in the Marshall Islands, and I show it to you because many people think that the Pacific is all high islands and rivers and Hawaii. It's actually not. And so a lot of the Marshall Islands, all of the Marshall Islands is atolls. And the average height above sea level is 6 feet. So impact of sea level, climate change, huge, very huge. Another reason that, by the way, there's a lot of flooding in the taro patches of Chuuk, a lot of sea level rise in the Marshall Islands as well, also causing compact impact. This is, we talked a little about nuclear testing, 67 tests over 12 years, equivalent to the megatonnage of 7,000 Hiroshima bombs. We can talk about the radiation and other effects. Afterwards, I've given 2 talks to this to the US President's Cancer Panel, and there's several reports about this, so if you have questions about this in particular, but make no mistake, there's islands there that are still contaminated. After 50 years of the promise that you can move back to your islands, they can't or won't. And a lot of contamination issues and cancers, latent cancers still arising from nuclear testing times. This shot I showed you because this is a picture of people from Ibai Island. Ibai Island is an island that is 66 acres in size. There's 10,000 Marshallese who live on this island. It is a short barge ride from a US military base called Kwajalein Missile Range. And why I show this is because, one, it is truly a picture of disparity. On the military base, there's a golf course, there's 2 swimming pools, manicured lawns. The Marshallese aren't really allowed to live there. They work there as the service jobs, and there's not even enough fresh water, sometimes potable water, so they have to go on a barge to go get water from the military base. So it shows you the level of infrastructure, of disparity in this one shot. The right lower hand shot of this is actually those people getting water from the military base while they're on the military base. And right now there is a drought in the northern atolls of the Marshall Islands, which is affected by climate change. And so climate change is a big deal down there. It's a huge deal. Water comes over the island. Okay, and this shot I talked to you about because part of this is about disparities. And with disparities, the United States spends about close to $8,000, this is not the latest, in per capita, per person annually. And of course, you know, in disparities, everybody's supposed to be part of the US Pacific, US territories, and so forth. And you can see the disparity because Chuuk, for instance, a lot of Chuuk migrants, a lot of Marshall Islands migrants, what do they get? They get $357. So that's about a 1 to 20 disparity. And so part of the US family, not really. The compact was supposed to have provisions to support health, education, and welfare. And so you can see there's a problem with this. If you talk about GDP per capita, US is about $48,000. Federated States of Micronesia, 2,000, RMI, 2,300, Palau's 8,000. So why are they migrating here? What kind of infrastructure do you think is going to go on with GDP per capita of $2,000 and health dollars in the range of $140 per person per month? Again, was the compact supposed to solve this? Not. Lots of questions about that, different theories, but I'm just showing you the raw data. And if you ever ask yourself, why are they moving in such a huge amount, very quick? So this is an article that was published from the Archives of Internal Medicine, which is as you can see, in 2011. And it studied the Medicare and Medicaid data in the US territories, including Puerto Rico, but also Guam, CNMI, and so forth. But if you look at the conclusion, compared with hospitals in the US states, hospitals in the US territories have significantly higher 30-day mortality rates and lower performance on every core measure for patients discharged after myocardial infarction, heart failure, and pneumonia. And this is in the territories. So you can imagine what it's like in the compact nations. This is actual data. So, and this is just published, analyzing the Medicare, Medicaid data. And so just want to present real data on the situation as opposed to just little snapshots. And so Federated Associated States, the health outcomes, if you have a health system like this, they're hammered by both the diseases that you think are in developing countries, cholera, Hansen's disease, tuberculosis, dengue, still very prevalent in these areas, typhoid. The infant mortality, 3 times to 6 times at the United States. Longevity in the Marshall Islands is 64, in the United States is 78. So you can see it looks very third worldish, but it also has an interface of non-communicable diseases like the United States. So it has the worst of both worlds. High cancer, high diabetes, high infectious disease. It's at this terrible transition. Why do they come to the United States? And so just for the women, you really appreciate this. In the Federated States of Micronesia, there's no mammography, 0. It's supposed to be part of, helped by the United States. And in fact, in the Marshall Islands, there's one in Madro that works some of the time. So, and that's just, that's standard of care. It should be some of the standard of care. Obesity rates and diabetes rates. So if you look at the United States, the 33% as a U.S. aggregate, but look at Marshall Islands, Federated States of Micronesia, and American Samoa. Much greater than this. Obesity, what does it drive? Some cancers, heart disease, strokes, hypertension, other things. Diabetes rates, American Samoa, 47%, FSM, RMI, this. But look at this, compared to Australia and US, you have this kind of, and so these folks have a very high disease burden, very high non-communicable disease burden. It can't be taken care of in their system. It's not prevented very well in their system. They move. They find the ways to get care. They go to Guam, they go to Arkansas, they go everywhere else. And this, I'll just go into for 2 seconds. This is, I graphed this life expectancy versus spending. So this is the expenditures. The US is way out here. And this is where the FSM and Palau and they're all in this range. Again, showing you the disparity. But their life expectancy is much lower than the United States. Just a graphic representation of the same thing we spoke about earlier. Now, talking about the compact. What is a compact? Kathy briefly talked about it, and so did the representative. So, the compact is a treaty with the compact nations that describes 3 things, 3 relationships. One is there is a military relationship. Essentially, that is, the United States has complete oversight of any military matters that happen there. Unlike other sovereign nations, the compact nations don't have any say over their military matters. It's the United States. Because of that, they are given economic provisions. They have some operating funds. You can see what they were given for healthcare, not a lot. And they're also allowed federal funds. And this is what the last relationship is, a political relationship. So because of this military oversight and the history, they can move back and forth to the United States. They carry an independent country's passport, like a Marshall Islands passport. They don't need a visa, they don't need a green card. They can come and work here and live here anytime they want. That's the law. They are legal migrants. They're not immigrants, they're not refugees, they're not illegal immigrants. They're not migrant farm workers. They are migrants because of the Compact of Free Association. And other things about the compact that define some of the nuclear settlement issues. Now, the objectives, the U.S. objectives of the compact were three. They wanted, in these countries, stable democratic governments. They wanted strategic denial, the military oversight, and they wanted these countries to achieve self-sufficiency. That was the U.S. objectives, very plain. This is what the compact is for. They accomplished the first two. The last one, the GAO report 2003, the goal of self-sufficiency and economic development has not been achieved. GAO report. U.S. Government Accountability Office report in 2006, economic self-sufficiency is not likely. So compact, did it fail? And what are we supposed to do about it? It was a federal negotiation. Why did they move? Well, part of it is you can't be self-sufficient, which was part of the target. There may be an issue. Now, the compact was a political negotiation, it's a treaty. The consequences, whether they're intended or not intended, that's what the compact impact is. What is the impact of implementing this treaty? And there's positive and negative impacts, obviously. There's federal support that's in place, but the structure of the compact is, remember, someone's my timekeeper, you know, I'm keeping the time, okay, is that the compact is designed so that over the life of the compact, the federal funds go down. Okay, so it's going to be a decreasing amount of federal funds. These funds are supposed to be put into a trust fund. And the trust fund is supposed to, at the end of the compact, be enough money to support the countries, at least as much as the theory was, as what the compact economic provisions provided. Okay, GAO analyzed that. Trust fund's not going to work. It's not going to reach that level. GAO data. Okay, so again, you have compact fundings going down, trust fund not robust. Where are the people going to go? USGO, economic self-sufficiency is not likely. Why this is important is because it really forms that context of health and education. So how are they going to build anything, health or otherwise? And that's the discussion with bills and legislation, is where are you going to strategize to make a fair level playing ground so that there is equity, not only health, education, and other things, and that we live up to what the compact was supposed to be. So it is an idea of planning. The compact impact, in my mind, personal, and all the negative parts, is a function of poor planning. Nobody really studied this. They put in a compact and nobody really looked at, and what we're seeing is that negative impact. What I suggest is before other bills and everything else happens, that people actually look at recommendations from the GAO and other forms of, how to address this in a proper way. And so this is, in 2004 there was a policy brief it was done in Hawaii, and already in Hawaii it was noticed in 2004. It's also important to note that any legislation that furthers the development of a national policy to advance economic self-reliance and to maintain economic and political stability of the Free Associated States should be encouraged. If you don't do this, it will hurt our country because people will move. You haven't structured and given them what they need, and you promise that. This is something that and I was part of that committee, I was part of this committee too, in Hawaii, the state of Hawaii, the the Attorney General's office, they made a task force report, and the report said the funding should increase federal fund compact impact funds. It should promote legislation to restore Medicaid, which is what the bill is about. That's the bill that Representative Hambusa is speaking of. Resources in COFA nations to increase that, so it's a plea, let the federal government increase resources to the federal governments. Don't leave the compact standing like it is. And then impact preparedness means that we have to get the people who are coming over in the compact more prepared before they leave. We have to do it on both ends. And so that's what that was about. And this is actually one of the things that was a report from 2010 of how much Hawaii was slaughtered by compact impact. And they added all these figures up, and they said in 2010, Hawaii had a bill of $114 million. That was because of the compact impact and the Free Associated folks who came over. Now, why this is important is the GAO just turned out a report in July 11, 2013, just July, and they said, in fact, a lot of these numbers that are coming out are overstated. There's not a true definition of who these Micronesians are, how to define them, and what they're presenting is a deficit sheet. So they add up all the deficits. They don't add in the contribution of the Marshallese. What do they contribute to taxes? How do all the free translation they do? All the other things. So it's not a balanced equation. All the impact countries are turning in an unbalanced sheet. And the GAO just said, we need to look at this, but presently what we're getting, the data isn't very good. So with that, I'm going to end here and say that there's other things we may be able to pick up in the discussion. Thank you.
I'm Kathy Grisham, and I'm from a landlocked state, Arkansas. I'm the executive director of St. Francis House, Northwest Arkansas, known as Community Clinic. We're a federally qualified health center, and we're home to the largest COFA population from the islands of the Marshallese on the U.S. mainland. Our focus is prevention and wellness, as well as the management of chronic diseases following the entire life cycle of our patients. We provide medical, dental, and behavioral health to all of our patients. We served over 30,000 patients in 2012. Half of our patients speak a language other than English, mostly Spanish and Marshallese. Half of our staff are bilingual, and we employ 5 to 6 Marshallese in various positions in the clinic: medical assistants, dental assistants, front desk coordinators. I want to thank you for the opportunity to speak on behalf of Congresswoman Hanabusu's bill to restore Medicaid to members of the COFA. This has been an issue in Arkansas, but because the concentration is in only one specific area of Arkansas, it's been very difficult to get traction. And in the year when the Affordable Care Act is being implemented, it's even more difficult. You probably wonder why in the world the Marshallese were attracted to Arkansas. I did. I asked for 3 or 4 years before I finally got an answer that made sense. There had been a minister in the Marshall Islands for a number of years. He retired to our region, and then slowly people started following him to our area, where they could find jobs that did not require schooling in the poultry industry. We're also home to Tyson Foods and lots of other poultry industry around in our area. The population in Northwest Arkansas of the Marshallese is only about 4,300, but it's significant enough that the RMI has established a consulate office in Springdale. In 2012, we served 1,600 Marshallese patients in our medical dental clinics, primarily in Springdale. The next largest provider of care to the Marshallese serves half the number of patients we do. The number of Marshallese that we treat keeps growing each year by about 15%. We employ medical assistants and offer full translation assistance in our clinics. We even post maps of the Marshall Islands in our exam rooms so that people understand that we are very welcoming to them. We're mandated to serve everyone who comes. Another part of our mandate is to track the care in our metrics. We have provided services just for the Marshallese in terms of diabetic education classes, We employed a community health educator as well as our own medical assistants for these classes. They were 12-week classes focusing on proper nutrition, portion size, exercise, information on obesity and diabetes. We were so hoping that this would make a difference. We just looked at our compliance after 6 months after the classes, and most of the participants have gained weight. Getting participation is very important. Our experience tracks much of what you said as far as disease and the prevalence. The rate of obesity and diabetes is epidemic. We see Marshallese patients with diseases the rest of the population has little experience with. Hansen's disease and tuberculosis. These diseases can stigmatize the Marshallese in the eyes of the general population. We're working very hard to make sure that they understand disease prevention is important, regular medical care is important, and that we want them to avoid these diseases that are frightful and scary to our general population. We track our outcomes on hypertension, diabetes, women receiving PAPs in the last 3 years. We've improved in every area except prenatal care. And it's mainly because the Marshallese mothers are not accustomed to seeking medical care for their children's births. They come to us in the second and third trimester of their pregnancy. So when our metrics were down, we tracked it back to figure out why. We're trying very hard to educate about the need for that early care so that the risk factors for both the mother and the baby are improved. The scope of medical care on the Marshall Islands is limited. Dr. Palafax covered that very clearly. They also pay very little money there. So when we charge on a sliding fee scale $20, and that includes all labs, it still seems very high to the Marshallese, and they don't necessarily pay it. In our clinics account receivables, Marshallese are the population with the highest account balances. Collectively, they owe us about $700,000. As an FQHC, we don't turn them away because of what they owe us. We counsel them about the need to be financially responsible, and we continue to provide care to them. I believe that the hope for the future health of the Marshallese will be through their children. And if the children are given full access to Medicaid, they will bring their parents to their appointments, and parents will better understand the principles of Western culture. The children will help the parents claim some power over their illnesses and disease. Medicaid eligibility will take away some of those barriers to preventive health care services for our Marshallese neighbors. Preventing illness and promoting health saves money and suffering for everyone. For clinics like ours, this bill would go a long way to covering some significant uncompensated care that compromises our financial resources and also those of our local community hospitals. We are going to serve our Marshallese neighbors with or without it, but it's challenging and expensive work. We are proud to be we're proud of our culturally sensitive program and the progress we're making, but we would very much like to see Medicaid restored to members of the COFA and help clinics like ours bring better education and better health care to our Marshallese Island neighbors.
Yes?
I have a question about the bill. Obviously, restoring Medicaid eligibility would help the islanders who have migrated to the U.S. would there be any benefit to the islanders back in their home islands? Would it help support better medical care there?
Not directly, no, not this particular bill. I know that there have been discussions, and Dr. Fox might know more about this, at the Department of Interior around those kinds of questions around the building up the infrastructure in the home nations, that a number of people agree that that is also part of the solution of having people have better health conditions. But this bill particularly is just looking at the restoration method. Other questions?
I can pick up on your point, and maybe a question for Dr. Halifax. So what are reasonable expectations of the healthcare systems in Madro, in Ponape, and Chute? What would be a, maybe not the best case scenario, but an optimistic scenario of what kind of quality of care you could sustainably expect in these places if you were to put additional resources there, preventive as well as treatment care?
So, one of the things about the compact, as some of you may or may not know, when they discussed the compact, there were no standards of health or education that were actually articulated. It was a set of money for doing healthcare and education. And I think maybe on both sides, folks thought it would work out, and hasn't quite worked out. But to answer your question directly, there's a lot of low resource countries that have pretty good prevention, and they certainly don't have the bells and whistles of some of the surgeries and so forth. But you can get a pretty good standard of health care and address a lot of basic problems. But again, with the compact and the relationship with the United States, there was an expectation that came with that. We supplanted our health system here and put it over there. So they gave them a very expensive health system that we can't even afford. So it's one of those really reconstructing that, but at baseline, if we work on the social determinants and a good prevention system and structure it so that the expectations of the folks at both ends align, then it will align. And also, a lot of federal grants have requirements that are U.S. requirements. So even if you can get it in the Marshall Islands, they can't apply because they say you have to have it at this standard. And so they can't even apply for that particular grant because it doesn't meet the U.S. standard. So yes, you can have good health. I think healthcare is not a matter of money, at the bottom, but certainly a lot of different parts have to align. I don't know if that.
Questions?
May I just add one thing? On the bill, I think there's one of the dangers of bills and so forth is when this Medicaid bill goes through, again, expectation management, is a lot of people think that's going to solve everything for the compact impact folks. Somehow that's a magic bullet. It's not even going to come close. The actual biggest expenditure in Hawaii is education, it's not health. And so it's one of really thinking through this, planning it out, and strategically looking at where we're going to go. Otherwise, you put in this bill, and believe me, I hope it goes through. They're going to still turn around and say, there's no equity here. And one of the biggest determinants of health is poverty and education. So if you don't link those two to the Medicaid, it's a loser. I don't mean it's a loser, I mean, yeah, thank you. Yeah, we only go so far, so.
This is a question for the women from Arkansas. I know that there is a state option under SHPA 2009 reauthorization to actually cover children and pregnant women, and I was just wondering if you can elaborate on some of the challenges, or if Arkansas has actually tried pursuing this option within the Medicaid state plan.
Arkansas does cover pregnant women, and the Marshallese do qualify for that. The problem is culturally, we have had a difficult time, as I mentioned, intervening with them to sign up early, and we have eligibility workers in our clinic. We try to do most of the legwork for everyone who doesn't have Medicaid that qualifies for pregnancy Medicaid. That is all about to change in Arkansas, with the Medicaid expansion dollars going to what they call a private option, which means people will sign up for their own private insurance, and the Medicaid dollars will cover their cost depending upon their income level. It may impact community health centers. It will impact community health centers very strongly, because there's also a provision in the waiver that the state is putting forth to change our business model. That's a nice way to say that we're not going to be reimbursed for seeing uninsured, low-income people and all the determinants of health, social determinants of health that affect compliance with care. And we're talking with the governor of the state right now about that, because it was sneaked in on us. And I hope that wasn't being filmed.
I was wondering if one of you could talk about insurance coverage rates in the compact nations. You mentioned, Ms. Guchin, that the health exchanges probably wouldn't be as effective there because of low wages. So I was wondering if you could talk a little bit more about that.
In general, most of the states where COFA migrants live are doing the state-based exchanges, and so each state is slowly revealing what those premium structures look like. The good news is that California and New York, the premium rates, especially for lower-income people, are lower than what kind of everybody was, worried about, and there really are very real lower premium costs. But those premium structures are still difficult for people who would have trouble affording it. I don't know about the subsidy structure for COFA migrants. I don't know if they're qualified for those.
They are.
They're
They're qualified.
qualified for those.
But they have to be in the U.S.
Right.
So.
Right. And then in their home nations, I can't speak to that.
In their home nations, there's not a very robust insurance coverage. It's pretty much in most places, in all three actually, it's highly socialized, meaning that you go to the hospital and they'll do what they can for you. There's a government subsidy in some places where you can actually, as a government worker, get an extra insurance premium, and it helps you if you get referred off island, and they have those in Guam as well. But insurance is not a big thing in any of the compact nations internally. And that there's an expectation, and I think it just comes with the culture, that the government and the ohana, the family, takes care of business. So if you show up, they take care of you. That's why the dollar or no money, and they'll take care of whatever needs to be taken as far as things go, and things don't go very far.
I have a question for Ms. Grisham. So I know that you mentioned there was a diabetes class. So how did the recruitment go for that class? I know you talked about cultural values, talking about getting pregnant women to the clinic, but what about like diabetes class? How did you go about recruiting them to be in that class, and are you planning on doing anything else in the future?
We will constantly do things in the future. It's been very difficult to get compliance. We have held them previously, and we've written small grants to provide them with food, to do cooking classes. We recruited from within our own patient population. We also recruited from the community because we wanted larger classes, thinking that they would influence each other, because that's the kind of classes that work with smoking cessation. You get everybody to encourage each other, and everybody's enthusiastic and shows up, but then it doesn't carry over or outside the classes. There's a drop-off, and I've been asking HRSA for 10 years for a cultural anthropologist to help us try to make this change and at the same time preserve the culture.